We're now going to welcome our final speaker today, Faye Evans. No pressure, Faye, who will present on the topic of preventing and managing diabetes in First Nations communities. Faye?
Thank you, Kathy, and thank you for the opportunity to provide this information to you today in Treaty 6 territory. I honor and thank the First Nations and Métis as our community partners and reaffirm our relationship with one another. I would like to start with a story. My nursing career started in 1980 at the emergency department at St. Paul's Hospital in downtown Vancouver. During welfare paydays, I would look after a significant number of First Nations individuals, mostly men, who were brought in because they were severely inebriated or were injured due to being so drunk. 2 weeks later, the same individuals were back because of alcohol withdrawal and delirium tremors. As a 21-year-old nurse, I could not understand why the predominant patients coming in with these conditions were First Nations. One evening in March 1994, I looked after Bill Reid, the famous Haida artist in the emergency department at UBC Hospital. Mr. Reid is known for his famous sculpture, The Spirit of Haida Gwaii. The image of the sculpture is featured prominently on the reverse of the 2004 edition of the Canadian $20 bill. Before he was transferred to his room, he ripped the page off his sketchbook, handed it to me, and told me that this was a raven for Faye. The next day, I asked my head nurse after rounds if I could keep the drawing. My colleagues were surprised that I had been given this present. One of them stated, "We have looked after him many times. He has never done that. Maybe he thought you were an Indian," in a very derogatory way. That day started my journey on finding out what it means to be an Indian. I have no affiliations, and I have no conflict of interest disclosures. The objectives are to identify the social and Indigenous factors that influence health, to discuss the chronic disease prevention and management framework, a guidance framework, to present the Diabetes Canada 2018 Clinical Practice Guidelines key messages on type 2 diabetes and Indigenous peoples. Indigenous people is the term accepted by the United Nations Declaration on the Rights of Indigenous People. Indigenous people of Canada are First Nations, Inuit, and Métis. There are 630 First Nations communities in Canada. 82 of those are in Saskatchewan. Roy Romanow is a Canadian politician and the 12th Premier of Saskatchewan. The Roy Romanow Report on the Canadian healthcare system was released in 2002. This report outlined suggestions on how to improve the healthcare system. The Honorable Roy Romanow in 2004 stated, and I quote, "A healthcare system, even the best healthcare system in the world, will be only one of the ingredients that determine whether your life will be long or short, healthy or sick, full of fulfillment, or empty with despair." So why are some Canadians healthier than others? The primary factors that shape the health of Canadians are not medical treatments or lifestyle choices, but rather the living conditions that they experience, known as social determinants of health. These include Indigenous status, gender, disability, housing, income and income distribution, unemployment, education, race, employment, working conditions, social exclusion, food security, social safety net, job security, and health services. The Indigenous specific determinants of health are historical conditions and colonization, language, heritage and strong cultural identity, self-determination and non-dominance, community readiness, economic development, employment, environmental stewardship, gender, housing, lands and resources, legal and political equity, lifelong learning, on and off reserve, social services and support, urban and rural. Preventing and managing chronic disease in First Nations communities, a guidance framework. First Nations and Inuit Health within Indigenous Services Canada supports a number of community services to prevent and manage chronic disease within First Nations communities. These programs are funded independently, which can be a challenge when trying to link with provincial and territorial systems and to support communication or teamwork between health providers and clients. These challenges reinforce siloed and disease-focused approaches and serve as a barrier to providing client and community-focused services. It was with these factors in mind that work on this resource, Preventing and Managing Chronic Disease in First Nations Communities, a guidance framework, was initiated. This framework is not meant to be an implementation plan. Rather, it serves as a non-prescriptive guidance document to help individuals and organizations reflect on their own efforts, consider where improvements could be made, and determine next steps that are relevant for their own contexts. The intent is to assist communities in responding to new opportunities as they arise, as well as in reforming and realigning their existing chronic disease program and services in both the areas of prevention and management according to their own priorities. Therefore, it is a non-prescriptive guidance document. It should not be viewed in isolation and should be utilized along other First Nations specific resources related to health and wellness with the cultural responsiveness framework that Dr. Jolisa Sakamis had given some information on, with a mental wellness continuum framework that was also developed by Indigenous communities. The vision statement of this framework reads, First Nations individuals, families, and communities attain empowered holistic health and wellness from birth to the end of life. In so doing, they are supported by healthy environments and a First Nations determined health system that is comprehensive, coordinated, culturally appropriate, and sustainable. This framework is grounded in 9 principles. These represent fundamental shared values that provide direction, set standards, guide efforts, and underpin all the chronic health decisions that First Nations partners in health make going forward. To be successful, policies, programs, and services aimed at addressing chronic disease in a First Nations setting need to be culturally relevant and safe, person, client, and family-centered, community-driven and focused, quality-based and evidence-informed, aligned with health promotion and population health approaches, responsive to the impact of Indigenous services, specific determinants of health, collaborative and coordinated, sustainable and accountable. 4 primary focus areas within the continuum of chronic disease prevention and management were identified. In these areas, improvements could have the greatest positive impact on the health and wellness of First Nations people, families, and communities. And these focus areas are collaboration and coordination, safe and supportive environments, personal and professional skills, information systems, and data sharing. On collaboration and coordination, suggested activities relevant to this area of focus that could move towards transformation include acknowledging the legacy of colonization and its ongoing adverse effect on First Nations health, engaging and connecting broadly with the First Nation community, recognizing, exploring, and acknowledging the First Nations individuals' preferences and barriers for reconnecting and integrating cultural resources and traditional approaches to care. Improving communication and collaboration with healthcare workers in First Nations communities who provide prevention and management support for individuals living with diabetes. Diabetes is complicated and the causes are complex. In safe and supportive environments, suggested activities relevant to this area of focus that could move towards transformation include, in clinical interactions, recognizing, exploring, and acknowledging one's own concepts of health, diabetes care, and assumptions about First Nations perspectives. Seeking to understand the relationships between the history of colonization and the current high rates of diabetes in First Nations people. Establishing practices that protect, preserve, and enhance traditional worldviews, knowledge, and language to support positive links to environments. Fostering positive relationships at the individual, family, and community levels that advocate for family and community resources for First Nations people. Implementing prevention efforts in screening with special attention to children and pre-gestational women, and assisting with the establishment of culturally safe interprofessional teams. Personal and professional skills. Health providers will have the training, skills, competencies, and knowledge necessary to deliver high-quality, culturally safe diabetes prevention and management activities. The Diabetes Canada Clinical Practice Guidelines are intended to guide practice, inform general patterns of care, enhance diabetes prevention efforts in Canada, and reduce the burden of diabetes complications, thereby improving the quality of care and health care outcomes of Canadians living with diabetes. And if you wanted to get the written version, this is the book that you can order. Unfortunately, you have to pay for it, and I think it's about $35, and you have to pay extra for postage. The ABCDESSS of diabetes care, Dr. Dawson has clearly explained earlier this morning, and they are A1C targets, BP targets, drugs for cardiovascular risk reduction, exercise goals and healthy eating, screening for complications, smoking cessation, and self-management. In preventing and reducing diabetes-related complications, the following are suggested activities that could move towards transformation. Building partnerships with the client and the diabetes healthcare team. Encouraging and supporting health behavior interventions. Individualizing and communicating your client's A1C targets. Risk assessment, vascular protection medication for clinical cardiovascular disease. Are your clients meeting blood pressure targets? Screening for microvascular complications. Keeping patients safe when they are at risk for hypoglycemia. Early screening for diabetes in pregnancy. Screening for gestational diabetes, and encouraging self-management, education, and support. In the area of information systems and data sharing, effective communication with clients and the diabetes health team in communities is essential. Suggested activities related to this area of focus that could move towards transformation include assisting communities to collect, possess, and protect their own data, respecting and adhering to the principles of OCAP, which is ownership, control, access, and possession, promoting quality improvement using evidence-based indicators to improve programs and services, completing the Chronic Disease Management Quality Improvement Program, CDM-QIP, on diabetes, coronary artery disease, heart failure, and chronic obstructive pulmonary disease. The key recommendations in the chapter on type 2 diabetes and Indigenous people are: management of pre-diabetes and diabetes in Indigenous people should follow the same clinical practice guidelines as those for the general population, with respect for and sensitivity to particular social, historical, economic, cultural, and geographic issues as they relate to diabetes care and education. Starting in early childhood, Indigenous individuals should be evaluated for modifiable risk factors of diabetes, for example, obesity, inactivity, unhealthy diets, pre-diabetes, or metabolic syndrome. Screening for diabetes in Indigenous populations should follow the guidelines for high-risk populations. To promote access to screening for remote Indigenous populations, access to standard laboratory testing is recommended. In its absence, point-of-care testing for hemoglobin A1C may be considered, where testing is associated with a quality control program and interpretation and follow-up expertise is available. Retinal photography screening programs may be used in Indigenous communities living in remote areas to promote access to screening. Attainment of healthy body weight prior to conception should be promoted among Indigenous women to reduce their risk for gestational diabetes. Nutrition counseling should be provided on healthy eating and prevention of excessive weight gain in early pregnancy, ideally before 15 weeks of gestation, is recommended to reduce the risk of gestational diabetes. Indigenous women identified as being at risk for type 2 diabetes planning a pregnancy should be screened for diabetes using fasting plasma glucose or hemoglobin A1C. If identified as having diabetes, they should receive preconception counseling that includes optimal diabetes management, including nutrition and physical activity advice, preferably in consultation with an interprofessional pregnancy team to optimize maternal and neonatal outcomes. Pregnant Indigenous women identified as being at risk for type 2 diabetes should be offered screening with an A1C test at the first antenatal visit if not screened at preconception. Pregnant Indigenous women with diabetes should receive management following the same clinical practice guidelines as those for the general population to improve pregnancy outcomes. In the postpartum period, Indigenous women with pre-existing or gestational diabetes should be encouraged to breastfeed immediately to reduce the risk of neonatal hypoglycemia. The infant of a pregnant Indigenous woman with diabetes should receive close monitoring for neonatal hypoglycemia with capillary blood glucose monitoring for up to 36 hours. Indigenous women with gestational diabetes should be screened with a 75-gram oral glucose tolerance test between 6 weeks and 6 months postpartum to detect prediabetes and diabetes and regularly thereafter according to recommendations in the Screening for Diabetes chapter of the guidelines. And lastly, Indigenous communities should be supported in initiating and maintaining culturally appropriate primary prevention programs for children and adults to assess and mitigate risk factors such as geographic and cultural barriers, food insecurity, psychological stress, insufficient infrastructure, and settings that are not conducive to physical activity. In conclusion, diabetes in First Nations communities is a public health concern that is complex. It is a negative consequence of colonization, the Indian Act, Indian Residential School, and the 60s Scoop. It is impacted by stigma, and it is also impacted by social factors that include education, housing, income, food security, and access to health care. Action is necessary to address these health inequities. What can be done? Some examples are obliterating racism and prejudice, acting on the Truth and Reconciliation Commission calls to action, and assisting in improving the social and economic conditions of First Nations people and communities. Senator Murray Sinclair is a First Nations lawyer who served as chairman of the Indian Residential Schools Truth and Reconciliation Commission from 2009 to 2015. Today, I would like to quote his words on reconciliation. Quote, "Reconciliation is really about trying to find a balance in telling the history of this country. The most important thing that we should be looking at is that there are a lot of Indigenous people who have made a positive contribution to this country, to their people, and to the relationship between Indigenous and non-Indigenous people who have largely been ignored by history and who deserve to be honored and commemorated just as much. And we should be talking about what to do about them. People are still trying to come to terms with their own sense of what reconciliation means and what it should mean. Reconciliation, he says, is about establishing a relationship, of mutual respect in ensuring that we do not tolerate anymore the fact that one society or one element of society believes that it is superior to another element of society. He also added that we are stumbling at the starting line of reconciliation. There's no question of that. We haven't even started the race yet, and there is a long way to go," unquote. I'd like to thank Senator Murray Sinclair for his words. And I'd like to thank the elders, the First Nations people, the healthcare workers that I have met in communities and established relationships with, who has provided me some teachings that are important to me in my journey of finding out what an Indian is all about. And thank you so much for staying on to listen to these last few messages. I would like to play a drum music from a powwow from one of the communities in Saskatchewan.
Thank you. Thank you for sharing those very powerful words and that drum song, Faye. Thank you so much for that. Thank you also for your very informative presentation and for sharing your powerful personal story, which framed your presentation. I really appreciate that. We're a little bit ahead of time, but we're going to start taking some questions from participants. The number for texting questions is on the screen. I do have a couple of text messages that did come, and so we'll start working through those. And I'm going to say that we have someone in the studio audience that's interested in asking a question. If you could just introduce yourself. Thank you for stepping up.
Good afternoon. Hi, my name is Sandy Helm. I'm with Peter Ballantyne Health. Thank you for the presentations. And Faye's probably going to giggle when I ask this, but I just have to at least highlight it to hopefully take it back for further discussion. We've heard today, and we all understand how important diabetes care is in not only the prenatal population, but that population with diabetes who needs continuing management. Any hope of this ever being considered a mandatory program with FINI? Thank you.
I apologize, but I really cannot answer that question. It's way above me, up at the ADM level, and I am sure that there will be conversations about that soon as we go past the hump of the issues with mental health and addictions, HIV, and SD, BBI, and hepatitis C. So they're hopefully going to listen to all of these issues, and hopefully we do not have to wait where more people are having amputations or we are having increased numbers of people attending dialysis.
Yeah, thank you, Faye. I knew you'd think I was not well if I didn't ask that here.
Great, thank you so much for your question. Any other questions from the audience? And remember, you're invited to text in your questions in as well. Faye, since we've got you on the question hot seat, there's a question that has come in by text regarding communities in Saskatchewan. Can you comment on what's currently being done or what's going to be done in the near future to ensure we start to finally reduce the microvascular complications, DN, amputations, dialysis, etc.?
The Aboriginal Diabetes Initiative funds several communities, pretty much all the communities in Saskatchewan, to look after upstream prevention and care and management for people with diabetes. Home and community care also provides diabetes care in clients who have disease. The way that communities decide on how to use their ADI dollars and frame their chronic disease or diabetes prevention and management is up to the community with guidance from program coordinators and ADI professionals that are working in each community. So it is really varied. And many communities today and many healthcare providers that are working in communities are really interested in looking at outcomes. It may not necessarily be outcomes that relate to hemoglobin A1C or blood pressure. It may relate to a feeling of love and belonging and feeling safe and establishing that self-esteem that could help clients be more motivated to look after themselves and drive the seat for their be the driver for their diabetes care and management.
And Faye, just a follow-up question, are these conversations that are had at the community level with the healthcare providers in the community?
Typically, the people that work in the ADI initiative in each community would have those conversations with their health director and hopefully integrate and work together with the home care nurses the community health nurses who provide upstream maternal and child care, especially in the area of immunizations. However, there is a gap because most First Nations communities in South and Central Saskatchewan do not offer primary care health services. So there are many people who also do not want to seek health care in the communities. They want to leave communities. There is the issue of confidentiality. So it makes it very difficult to have a coordinated approach. And chronic disease care and management is not a mandatory program. And that is diabetes. Although it is funded, it is not a mandatory program.
Okay, thank you, Faye. I'm going to ask a question for Katie now that's come by the text. Katie, how can nurses working on First Nations communities work with NIHB to have the Freestyle Libre, and then in brackets for clients with type 2 diabetes, be a suitable substitution for those clients already eligible for 200 plus strips per month? I ask this for two reasons. The sensors are either more economical or of equal monetary value to testing strips, and it can be reasonably hypothesized that long-term costs to NIBH HB would be reduced owing to an increase in normal glycemia and a decrease in DM-related morbidity.
It's a great question, and I get it quite a bit, especially with the lifestyle, and the NIHB is aware of that as well. So number one, I'm going to emphasize this: if something doesn't get approved by Drug Exception Center, you have the option to appeal it. So go ahead and use that process and see what you can get. Secondly, CADTH hasn't looked at the freestyle. And so we're trying to figure out, well, where can we go next? And actually, the Ontario Pharmacare, the pharmacy, or the province of Ontario, is actually looking into the lifestyle right now, and that that testing or the research should be done in May. And so we're waiting until that is done to see what their recommendation is regarding the cost analysis, cost-benefit analysis that we do with all drugs and technology.
Okay, thank you very much for that. I had a follow-up question for you, Katie, from your presentation. You talked about your role. Does part of your work include providing mentorship to healthcare practitioners regarding pharmacological options? Healthcare practitioners who can prescribe?
Yes, so a lot of what I do is that liaison work, and I also work with a lot of the different programs advising around non-insured health benefits, but also in my role as a pharmacist to, talk about medications and where they're effective. And a lot of times communities will invite me to come in and they set the agenda. And so if they have healthcare providers there, sometimes they'll have elders there. I had an elder day one time where all we did was talk about drugs and medications for diabetes, and I sat down with all of those individually afterwards. And to go back to the question of, are those people actually taking their medications? And so the one elder I sat with, and she got her medications blister packed every week, but she said she only picked out the one. And so, she opened up the blister pack and took out the one medication. So asking those questions and really getting to know your patients is important. But yes, that's probably my main 90% of the work I do is actually around drug education. And regardless if it's for the patients or for the providers, that's what my role is.
Okay, thank you so much for that. I have another question for you, Faye, and then I have a question that I'd like both of you to respond to, but I'll ask Faye's question first. Ask the question to her first. Faye, I was really struck in your presentation when you talked about, in the framework, the safe and supportive care, that as healthcare providers, we need to explore our own concept of health, diabetes, and assumptions about First Nation health. What struck me was how congruent that was with what Dr. Sasakim was told us about self-location in in her framework, the cultural responsiveness framework. At least I see the connection there, and I'm not sure if you do or not, but it sounds like you've done some of your own reflecting from your personal experience right back to when you worked at that Vancouver hospital. Can you provide suggestions as to the tools that healthcare providers can use to explore and reflect on their own concepts of health, diabetes, and assumptions about First Nations health, so that they can be more have that connectedness and that connected relationship?
Most recently, I listened to the Massey lectures, 2018, and you can access that through the CBC under podcasts for ideas. And it was Tanya Talak, I can't remember her last name, but she visited several cities in Canada, Vancouver. She started out in Thunder Bay, traveled to Halifax, then to Vancouver, to Saskatoon, and ended up in Toronto. And she has done a lot of research on health inequities. And listening to her, it was very powerful. You get an understanding of what is the root cause of all of this. And I think Dr. Jolie Sasakamas explained that very clearly this afternoon. I haven't really read any books that would speak to how you could relate to First Nations people. There are many resources that are targeted for First Nations people in the pictures and in the content. But really, I have to say that you have to develop that relationship with that First Nations client, family, or community. You have to take the time. It takes time to be trusted, and it takes no time to have that trust removed if you've breached their confidence and you've breached their confidentiality. So I have to say that it's still 38 years. I'm not anywhere close to where I would like to be, but I'd like for you all to be patient and to take time to get to know your client, get time to know the First Nations individual that you are with. He or she or they have a story, and it's really important just to listen to what they have to say, and you will find that you will get direction from those stories.
It sounds like, too, reflecting on your personal story that you shared, and the fact that you have worked in quite a few different places in the world with different populations, that it's that openness as well, that personal openness to understand what it is to be an Indian is what I'm paraphrasing, but so it's that openness that you described as well that would facilitate you getting to know your patients and your clients and your communities.
I agree with you, Kathy. I worked in Honolulu, and I was setting up clinic as a family nurse practitioner in a Hawaiian community, and I arrived at 9 o'clock, and I'm driving down the path. It takes about 10 minutes to get to the health center, and already they know that I'm arriving. Oh, there's a new nurse. And so I arrived and I said, "Good morning, let's set up clinic." And they looked at me and asked me, "Who are you? Are you local?" And I said, "Of course I'm local." He says, "Well, you don't behave like one." I said, "Oh, okay. Well, let's set up clinic." "Well, we want to talk story. We want to get to know you." "I don't have time for that. Let's set up clinic." So they agreed. They set up clinic. And we waited and waited and waited till 1 in the afternoon because no clients arrived. They knew that the clients arrived at between 1 o'clock and 4 o'clock. And so they would spend the time sitting together, getting to know each other, discussing the pressing issues, looking at solutions together. And that's how you got to know each other. So that experience was very powerful for me, and I learned a lot from that.
Okay. Thank you for sharing that. I have a question on text, and I think it's for both of you, and maybe Katie, I'll get you to respond first. The text is very informative and eye-opening for someone like me who doesn't know much about Indigenous cultures. Great recommendations too. My question is, how can we encourage access and compliance to whatever services are available now? So when you talked about the client who took one pill out of the bubble
exactly.
pack.
I know, and making time for that. I think we've already touched on it, and it's mapping all of those different services and opportunities to bring them together and to be able to promote them in a way that's open for people to actually say, you know what, I might feel safe doing something like that, or that interests me, and why. And I should try it out. And really to have some of those things available are really key in knowing, okay, well, this could be an option for this patient and that kind of thing. I know even for non-insured health benefits, when patients do not reside on a reserve, sometimes they don't even know that that's an option for them. And so I come from Yorkton, Saskatchewan, and in my community there, some people were asking my dad to get a ride to Regina for healthcare. And I said, well, they can get benefits for that. Medical transportation is a benefit, and they didn't even know, because they didn't have that available. And so even you as a healthcare provider, if you know that, maybe share that information with them and say, hey, did you know about non-insured? Did you know you have access to those with your benefits and that kind of stuff? So even just having that knowledge, but then sharing that, I think is a huge part.
And that's a good point you make, is having the knowledge. So therefore getting connected with the resources that are available, so you know what's available, so you can connect people.
Yeah.
Yeah, that's a very good point. Faye, can you respond to that?
Could you repeat the
Absolutely.
question, please?
Okay, I'll just repeat how can we encourage access and compliance to whatever services are available now?
You do have to find out what other factors are affecting that person's ability to access care. It could be transportation. It could be that they have 10 people living in their house with all kinds of problems. It could be that they're living with mental health issues. There are people in community that are trusted sources that they go to, community health workers, nurses, mental health therapists. It's difficult to navigate, and there is no cookie-cutter approach. Every community is different. Every health center is different. The programs that are funded are the same, but sometimes the things that they execute the programs are different, and it's based on their priorities, their cultural needs, and different outcomes that you may not be aware. It's very complicated, and it's very complex to navigate. But I do have hope that we will continue to be able to reach out to First Nations individuals, families, and communities to be able to do whatever it is that is a priority for them, so that it will motivate them to take better care of themselves physically, especially in the area of diabetes prevention and management.
And of course, events such as this, which make the continuing education of healthcare professionals accessible, also important. So I would say that we have a number of participants that are going to have access to some resources that maybe they didn't have access to before. Yeah. Any further questions from the? Yes, Dr. Dawson. Sure.
I really think this has been very informative, and the last question is the summary of what we really can do. And I would like to give you some messages that I've interpreted. It is important, it is so vital that we get participation from the people themselves, from the communities themselves. It is no longer valid for us to just tell them what to do. We have to help them to have educated people. I would love to have every community. We have 197 communities that we are serving in our mobile clinic. That's a vast number of communities. I would like each community to have a health resource person already available. It doesn't have to be a doctor. It doesn't have to be an RN nurse. It doesn't have to be a nurse practitioner. It can be somebody who is the go-to. And we can use telemedicine and other methods of communicating with a local person. But that person, as Dr. Saskamoose advised us, can tell us what the local community looks like, what would work in that community, as opposed to what would work in another community. We in the healthcare field are tied down by our own past, and maybe the First Nation people are as well. For example, the question that was asked by Katie, oh, well, let's have a pill box. And so they have a pill box to distribute, and you open it, and this person took out the one pill, and that's it. Yeah. Well, that was our solution. Our solution is, oh, we'll get the pill box. That's not their solution. We have to ask them, what would they do? Does it need to be a different appearing box? Does it need to be whatever? The second thing I'd like to make a comment on and ask Katie, just on the practical level, the CADTH and other resources identify, remember what she said, if you have to judge a drug, whether it caused severe hypoglycemia or not severe, it doesn't have to be severe. Let me ask a question. How many would like, or you'd like to have the airline pilot of your plane be taking a sulfonylurea, who could have a mild hypoglycemic, but not a severe one, or another agent which doesn't have it? I would much rather fly with a person who's not going to have any hypoglycemic reactions. And the second thing is, all of those answers, and I'm not blaming CADTH, they have to do this, but all of those answers of what we should advocate for our patients are not provided from the point of view of the patient. They are not saying, what would you take? What would you like? What would you find acceptable? As opposed to, I think this is the best agent or not the best agent. And if you can find that patients willing to take it, it is so much better. If I tell you, gosh, you have a weight problem, and we could give you a pill that really works and is cheap, but it produces weight gain and hypoglycemic reactions, that wasn't considered at all by CADTH, nor did they want it. They have a bias in saying we've got to keep the prices down. I'm fully sympathetic with that. But we should understand that us imposing, whether it's CADTH and ourselves as doctors, imposing recommended medication, recommended treatment, recommended lifestyle on the First Nation people is not the way to go. We have to get to ask them, what will help you, and what can we do to help you get control? I really think that's the important message. Thank you.
Thank you, Dr. Dawson. And seeing that we have no further questions coming by text, then I will, I think Dr. Dawson has very capably ended out our question and discussion this afternoon. So I'm going to wrap up the day, unless I have more questions. No, I don't. Any questions here? So thank you for your questions and for your participation in this important continuing education session today, where our speakers discussed the 2018 Diabetes Update Guidelines from a few perspectives. This session has been videotaped and will be available on the CEDN website in the near future. Remember, registered participants can access the speaker's slides presentations there as well. In addition, participants will receive an email later today with links to NIHB and CADTH, as well as other links mentioned by presenters today. On behalf of participants today, I would like to extend a big thank you to our presenters, Dr. Keith Dawson, Dr. Jill Newstead Angel, Dr. Jolie Saskamoose, Katie Windle, and Faye Evans. This has been a very informative day that has very well connected the 2018 diabetes guidelines to practitioners at the point of care. Before we conclude today's events, we have just a few housekeeping items. As mentioned earlier, the evaluation forms will be sent to your email. Follow the link provided to complete the online evaluation form. Please take a few minutes to complete the evaluation, as this information is used to help with the planning of future continuing education events, and you will receive your certificate of attendance once you have completed the evaluation. Thank you to Media Productions at the University of Saskatchewan in Saskatoon. A special thanks is extended to Faye Evans, Sandy Hallam, and Jeanette Baer, and everyone who assisted in planning this e-learning session for all of us today. And of course, the most important thank you goes to all of you, the participants. Thank you so much for joining us today. Please visit the CEDN website, www.usask, it's at the bottom of the screen, to find out more about upcoming events, workshops, and conferences. We look forward to seeing you again soon.